Hi, I'm Adam DeVore here with Emily O'Brien from the DCRI. Thank you for joining us, Emily.
Thanks for having me.
So earlier this week you presented some interesting science out of the ORBIT Registry. I was wondering if you could tell us first just a little bit about that registry and then about your study.
Sure. So the ORBIT Registry is the largest outpatient register for atrial fibrillation in the United States. Patients are followed over approximately 2 years, and information is collected on demographics, treatment, clinical events that happen over follow-up, and other risk factors for stroke and bleeding.
That's great. And I know you all collect quite a bit of detailed information. This particular study that you presented was on a bleeding score. Can you tell us a little about that?
Absolutely. So as you know, patients who have atrial fibrillation are at greater risk for stroke than patients without atrial fibrillation. So anticoagulation therapy is an important component of therapeutic decision-making for patients with AF. While anticoagulation therapy is effective in reducing stroke risk, it does convey an increased risk of bleeding. So we were interested in identifying factors that were associated with increased risk of major bleeding in patients who are anticoagulated. And to do that, we used information that from the baseline enrollment form that was clinically relevant and had biological plausibility as a major bleeding risk factor, and then built a regression model to identify the factors that were significantly associated with bleeding, and then from there identified the 5 strongest predictors to create a simple risk score.
And what are those variables, and how is it different from some of the other bleeding risk scores?
Okay. So great question. So the score is ORBIT. So the O stands for older age, the R stands for renal insufficiency, B is for bleeding history, I for insufficient hemoglobin, hematocrit, or history of anemia, and T is treatment with antiplatelets. And one thing that really is what we think a major advantage over existing scores is that all of those data points are readily available to the clinician, so the score can be calculated easily and can be done in your head to estimate a bleeding risk for your patient.
And has a great name. That's good.
And has an excellent name, yes.
Well, that's good. And so how are you hoping this gets implemented, or how would you like to see this move forward?
Well, I think that in the era of patients who are receiving warfarin and novel oral anticoagulants, this is a score that can be used in contemporary populations, and we hope that it will potentially help providers to flag patients who are at increased risk for serious bleeding, and then also to identify the modifiable risk factors that can potentially reduce that risk.
Well, that's great. Well, Dr. O'Brien, very exciting stuff and certainly very relevant for patients. So thank you for your time. And if you'd like more updates from AHA, please follow us on the Duke Fellows blog.